these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office. Experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all. In-depth discussions.
Breaking it down into simple terms. We hold these truths.
We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
Hey everyone, welcome back. Today we're going to be talking about what if Medicare for all was a thing right now? How would we be dealing with coronavirus? And to help us with that discussion, I'm bringing back my friend Chris Jacobs, and he is the author of the book, The Case Against Single Payer. So you can probably tell where he's at on this issue. And he's got a decade of experience on off and on Capitol Hill. He's worked as policy director for American Next, which is a new startup think tank, and a senior policy analyst for the Heritage Foundation and the Joint Economic Committee's Senate Republican staff. Hey, Chris, thanks for being back.
Thanks for having me.
Okay, so we'll get right into it. I guess let's do a little recap of what you and I talked about months ago when we were discussing Medicare for all in your book. So from the top line, what is the case against a single payer healthcare system?
Well, I think broadly speaking, it would be bad for our economy and bad for our nation's healthcare system. It would require huge tax increases, significant job losses, and then would also destroy the healthcare system that has produced enormous amounts of innovation for not just the American people, but patients across the globe.
But why is that? Because we always say that, and we're like, this is the outcome, and I'll tell you what, voters just don't believe us. They really don't. So, I mean, how do we dive a couple layers deeper into that and explain why, when you shift to this kind of system, it results in worse healthcare? We know why it results in a worse economy, right? You mentioned that. You definitely have to raise taxes. But why is the healthcare worse?
The basic premise of single payer is that you use the government's monopoly on care to pay doctors less, to pay hospitals less, to pay pharmaceutical companies less, to pay everyone less. The premise behind single payer is that doctors will get paid less to do more work. And when you explain it in that kind of very simple logic, I hope people will understand that there's a problem inherent in that.
Yeah, I think so. I would hope so. That's basic. That's a basic supply demand issue. If you purposefully decrease prices, you will get less supply. And in the case of healthcare, less supply is pretty meaningful. It means less doctors, less capacity to give care, and less innovation and less investment in innovation and research and development.
That's exactly right. You would have doctors who would might quit because of single payer. You have physicians who might go into other lines of work. You might also see college students say, you know what, I really don't want to go into medicine if I'm going to have all these regulations imposed on me and get paid less. I'm going to go into finance or some other line of work. And so there would be a massive shift away from the medical personnel who have been the first responders on the scene of the coronavirus pandemic, trying valiantly to protect American patients.
Yeah, we would simply have less of them. And so that sets the stage. Like, okay, if we had Medicare for all right now, or we had implemented it, a few years ago, and we were living within that system now, how would we be responding to coronavirus? And just let me say this, I don't think that the problems with Medicare for all are even disputed. These things that we've laid out, I've never heard anybody even dispute that. Now Democrats talk past it, but I've never heard them come up with an argument against it. That's just a fact. And I think I just wish they were more honest and open about the fact that this is the price they are willing to pay, doubling, possibly tripling your taxes, plus less health care, as long as they can say that everybody is technically covered. That's the trade-off that I wish they would be more honest about. But it is a true trade-off. It's undisputable.
Sure.
And so and then what would that mean for our current capacity to deal with a coronavirus situation where actually the number one question we have is healthcare capacity, meaning how many doctors do we have? how quickly can we produce new medicines, and how many people can we fit into a hospital? How big can we make our hospitals?
Right, and I think that's the inherent downside of single payer. There are some on the left who have actually come out and said that single payer will lead to rationing of care. The head of the People's Policy Project, which is a socialist think tank, has admitted that some, for instance, the Urban Institute's estimates of single payer, he says that those are inflated because the Urban Institute says more people will demand free care. And this person's response is, well, yes, but there are limits on supply, and therefore not everyone will get that free care that they're seeking.
Exactly.
in other words,
fully agree.
You said the quiet part loud.
Right.
And it won't cost as much money as people like us conservatives claim, because government is going to ration care and say you're not going to get care. That, in a nutshell, is the problem with single payer generally. It would certainly present obstacles in a pandemic environment.
Yeah, and we're already seeing that if we compare our country to how other countries have been dealing with it, and so how is that? I mean, have you been looking at how hospital capacity has been strained in our country versus other countries?
Well, and the metrics are difficult to compare in terms of apples to oranges, and who has the most reliable data and from what year and all that sort of thing. But as I lay out in a chapter of my book, when I'm talking about the international comparisons, the UK and Canada have far fewer hospital beds than the United States. They also have fewer of things like X-ray machines, ultrasound machines, MRI machines. They do not spend nearly as much money on the kind of specialized care, equipment, ICU beds, that sort of thing that the United States does. And so all of those trend lines show how there would be less capacity if the United States went to a single payer system for the kind of care that coronavirus patients need.
Yeah, and I'd retweeted an economist who wrote out our numbers of ventilators in our country versus all other Western countries, and by far on a per capita basis, the U.S. has the most. The only country that comes even close is Germany, but I think we still have like 3 times more per capita, or almost 3 times. I can't remember, but it's a lot more, like by far. And we're also the only ones who seem to be mass producing ventilators at this point. We're the only ones who seem to be able to mobilize in that direction. It seems like we're going to be well over capacity on something as life-saving as a ventilator.
And you've seen also there were some worries that ventilators would have to get rationed here in the United States. Thus far, it doesn't look like that's happened. Compare that to Italy, which has a single payer system and has had to ration ventilators, and they've made very difficult choices, and they're coming up with rationing criteria, et cetera. Thus far, and obviously there are a lot of variables in this situation in terms of the spread of the epidemic, how many people get infected, age rates, comorbidities, and that sort of thing. But on the pure basis of results, the United States, I don't believe has had to ration ventilator access thus far, whereas a single payer system like Italy has had to do that.
Yeah, I have not heard of any case, and I've heard people say that there have been no cases. At least in New York would be the place to look to. That's the only right. It seems to me to be the most strained, but even then, it's never been broken. And I believe the governor has said that everybody who has needed it, has needed care, has gotten it. It's just that we couldn't save them. For which is terrible. What about the Joe Biden response, which would be let people just buy into the system? Have a public option that we can buy into. He views that as a more moderate option. What do you say to that?
Well, it's problematic on several levels. First of all, the Medicare Trust Fund is scheduled for insolvency in 2026, which isn't that far away. The second problem is that Biden's plan in particular will have the effect, you can argue whether it's designed to or not, but I think will have the effect of dismantling the employer-based health system over time. Specifically, Biden's plan would increase the Obamacare subsidies, and it would also allow people with employer-sponsored coverage to receive those Obamacare subsidies if they qualify. Right now, the technical term is a firewall that says if you have an offer of affordable employer coverage, you cannot qualify for Obamacare subsidies. And that's prevented some of the switching in terms of people going to the exchanges and so forth. Biden would demolish that firewall, and his plan very specifically says if you can get a better deal from the exchanges, you can go to the exchanges. Well, that sounds very well and good, but number one, it will increase the cost of the exchange subsidy significantly. Number two, the more people who go on the exchanges, at some point an employer says, is it really worth my time and effort to maintain my employer plan if half of my employees are on the exchanges anyway, and so they'll just dump the rest of their employees onto the exchanges. So it's designed to lead to single payer, just in a slightly slower and less transparent fashion than the Bernie Sanders and the Ocasio-Cortezes of the world.
Yeah, and you said you're not sure if it's intentional or not. I think it is. I've heard plenty of Democrats say that out loud, that they know this is just a slower glide path to the exact same outcome.
I quote this in the book that the father of the so-called public option, Jacob Hacker, said in a speech in 2008, well, people think this is a Trojan horse for single payer. He said it's not a Trojan horse, it's just right there.
Yeah, it's just true. And I mean, that's true by their rhetoric, and also, as you noted, intuitively, we can see that process take place. Yep. And it really gets into this kind of ethical question or moral question that we fight about. Which is they just honestly believe that if they can say that everybody's covered and say that it's a right, then somehow that's a superior outcome. But you look at Canada, our neighbor to the north, and it's a right up there, but they have a right to also wait 6 months for an MRI. I mean, and their wait times are atrocious. They come down here for life-saving surgery, like hundreds of thousands a year. Right? What is the actual? Do you know the number off the top of your head? I know it's high.
So I believe it's like 300,000.
300,000 people.
And of course, it's traveled down to the United States, to the lower 48 from Canada for care, and then there's about 1 million people on waiting lists in Canada, and this is in a country with a population of only about 30 million. So it's wow. A significant share of that population. Yeah. Britain has about 7% of its population on waiting lists, and the waiting lists have gone up 50% in the last 5 to 7 years in Great Britain. I think you hit the nail on the head. Canada's Supreme Court in 2005 actually opined that access to a waiting list is not access to care. Bernie Sanders talks frequently about making healthcare a human right. As I pointed out, the week he introduced his bill in 2019, nothing in Bernie Sanders' legislation makes healthcare a right in the sense of being a legally enforceable right. You have the right to have your care paid for if you can find somebody to take care of you.
Yeah.
That's a big if. If you can't find somebody to take care of you, you can't go sue HHS. You can't go sue Bernie Sanders and say, I can't get care and receive damages. It is not a legally enforceable right in any sense of the word.
Yeah, well, and it's just an irresponsible use of the word right, like a period. I mean, because you can't call anything a right that requires the service of somebody else. And I got into this discussion with my friend Joe Rogan on his podcast where he brought up the often asked question, which is, well, why can't it just be like a fire department? You have a fire department, and we all live as citizens of a country, and we sort of have this right to be protected from fire by a fire department. It's kind of the same thing. And it's a slippery question. You have to wrestle with that one for a second. I was caught off guard by it at the time and thought a lot more about that comparison later. I was caught off guard by it because to me, it's so obvious that it's apples and oranges, both as a matter of scale and a matter of what exactly you are promising somebody. And the way I put this now would be this. A fire department is protecting the public from an externality that is a threat to their safety. And that actually is a right that is outlined in the Declaration of Independence. Life, liberty, pursuit of happiness, and the public and safety is mentioned in the Declaration of Independence. But that's quite a different thing from healthcare, which is not necessarily an outside threat that is easily identifiable, such as a fire or a criminal in the case of police, for instance. And I know this gets really philosophical and people are just kind of shrug it off, but these are actually really important principles as we think about how to engage in public policy.
Sure. I actually start chapter 6 of my book answering that question: should healthcare is healthcare a human right? Should healthcare be a human right? And my response to that is no. I do not believe the government should ration healthcare, because by agreeing that healthcare is a right, then government gets to define what that right is. And by saying what healthcare you should get, that also by implication will tell you what healthcare you will not get. And I don't want the government in the business of rationing care, as it is in Canada, as it is in Great Britain, as it is in other systems with single payer. And I think that's the best argument for why against this concept of making healthcare a human right.
But and we should also remind everybody, it doesn't mean we don't want everybody to have access to healthcare. Like this,
sure.
We just recognize the reality that we live in, which is it's not as if I'm hiding all this free healthcare that I just don't want to give you. But if you listen to Democrats, you would think that's what's actually going on, that the government's just preventing you from getting access to this care that would otherwise be totally available to you. But that's just not the world we live in. And the fact that they've promised that so often over and over, it creates a ton of resentment in society. And I think this is the case with any issue. If you promise it over and over again and make people feel like they're being sold out, or that they're being prevented unfairly from accessing some kind of benefit that is rightfully theirs, you tell people that over and over again, it makes them angry because they feel like this injustice has been leveled against them. And that's such a horrible mind trick to play on the American people. It's not just healthcare where this happens. It's very frustrating. And so I feel like we're just trying to lay some reality out here. And it doesn't mean we don't want everybody to have access. I think we have to always have that as our goal. I wouldn't deny that at all. We have to do it responsibly.
Yeah, the left shows no limits on what they are willing to provide with somebody else's money.
100%. And the counter argument too on the traveling and care, because I remember this happened to me on Twitter, because I pointed out almost 300,000 people leaving Canada to get real care that they need in the United States, and somebody was like, well, about that same amount traveled from the U.S. to Mexico to get care. And first of all, there's a scaling problem there. Okay, we're 10 times the size of Canada, so that's on a per capita basis. We leave the U.S. far less to get our care. Also, I had to point out the reason Americans might go across the border to Mexico is to get cheap drugs and maybe other cheap procedures, knowing full well that those are generic drugs not approved by the FDA or procedures that they're just not as too important, and they don't care about the reduction in quality or standards, and they're willing to pay pay a lesser price for that. No cases are these I won't say no cases, but these aren't life-saving things. It's a cost issue, and that gets to the real problem in American healthcare, which is it just costs too much. And trying to figure out how to make it cost less would really save us all a lot of headache and make insurance more affordable, make these problems. Because I don't want to, and you wouldn't argue this either, that our healthcare system is well run. It needs improvement, but the main problem is cost. So how do we how do we tackle that?
And I think that shows the problem of the leftist approach, which is really make everything free, which will induce far more demand for care, and then ratchet down the supply by rationing things.
Yeah.
And it's a simple supply versus demand economic issue. I think there are ways to reform incentives in the system to make people smarter consumers of care, particularly when so much of healthcare spending is on chronic diseases, diabetes, high blood pressure, chronic heart failure, those sorts of things. The left often uses the example of the heart attack patient. You obviously can't shop around for care when you're in that kind of in extremis scenario. That's actually the anomaly in healthcare, that most healthcare is spending is on chronic long-term diseases, as opposed to acute emergencies.
And I want to get to some solutions that you might have, or some suggestions, but I'll maybe do that towards the end. Let's stick on this theme of the price control issue, right? Where like, as you noted, the left is very simple in their thinking. They say, well, this is too expensive, so we'll just pass a law that makes it less expensive. Look at what a good person I am.
Right.
Like, okay, guys, like there's no second, third order consequences to that. Like, oh, we want people to get paid more. We'll just raise the minimum wage. Just make people pay other people more. It'll just put it in law. Look at us, pat ourselves on the back. It's like, guys, like, who do you honestly believe? Like, no second, third order consequences to that, really. So HR 3 is that price control that I'm talking about, which is the flagship drug pricing bill that the Democrats passed out of the House, won't go anywhere in the Senate, and it's effectively price controls. They try to call it Medicare negotiation, but they're really not what's happening here at all. And I guess so. The question is, what would that do, especially as it relates to COVID-19? I mean, as we're looking for treatments right now, we have a lot of companies working on those treatments and vaccines. And the question is, and also testing too. I mean, so many companies like offering up new innovations in testing, getting faster and faster, figuring out how to produce more of it. You got to ask yourself, if you put those price controls in place, where would these companies be? Would they even exist?
Yeah, and I think that's the issue. And certainly, companies need a rate of return on their investment. And if they don't get a rate of return because of price controls, they will, instead of investing in pharmaceuticals, they'll invest in computers or IT or something else.
Mm-hmm.
Or
the biotech startups won't start up in the first place.
Correct. And so it's you see the benefits in terms of your price goes down, and this is the problem, kind of the forgotten man aspect of it. You don't see the benefits in terms of the drugs that never get invented, or the patients that never get cured because the drug never comes onto the market.
Yeah.
Because you have things like price controls. My example when it comes to price controls and the leftist mentality, I wrote an article a couple of years ago about, and I don't know if you watch The Simpsons or are a fan, how Dr. Nick Riviera explains Obamacare and explains the liberal mentality on this. Dr. Nick, in one episode of The Simpsons, offered to perform any surgery for $129.95. The problem is, would you want to have your surgeon be a doctor who graduated from Springfield Barber College? And that's the point. Every time you arbitrarily lower prices, quality of care often suffers.
Yeah. Or like you said, they just don't produce the drugs in the first place. And it's a
Right.
cheap argument to make or from the left anyway, because there is no counterfactual, right? You could put in price controls and all of our drugs would all of a sudden be at a certain price, but we would never have any new drugs. And they would just say, look, we solved the problem, but we would never be able to prove, because again, you can't prove the counterfactual that of all the drugs that were never developed anymore in the future. And although plenty of studies, including from the Congressional Budget Office, have shown very clearly that we'd have, approximately 30 less cures. And these could be major cures. These aren't just, these might not be, these are real things that people need. So you wrote recently in a Federalist article, you talk about the financial disruptions that hospitals are seeing right now from COVID-19 and a shift in their patient mix, which seems to be a consequence of both COVID-19, but actually mostly the fact that we're not allowing our hospitals to see any other kind of patients because we're trying to keep our hospitals open. I mean, that's definitely the problem in Texas, and I hope we're reversing that policy now. But it's been harmful. So talk about what you wrote about here.
Yeah, it's a simple math problem. As you pointed out, in many areas, elective procedures have been canceled, and thankfully some areas are not seeing any COVID patients. But even in areas that are seeing COVID patients, you're replacing elective surgeries like hip replacements, knee replacements, mastectomies, those sorts of procedures with coronavirus patients. And the average payment for a surgical procedure, an inpatient surgical procedure, is about $40,000. The average payment for a non-surgical procedure in 2018 was less than half that, under $20,000. So when you're replacing high-paying patients with lower-paying patients, hospitals end up having major financial disruption. And so you're seeing hospitals actually having to impose pay cuts, furloughs, all these sorts of extreme measures because they're having interruptions to their patient mix. That's exactly what would happen if you ended up with a single payer system or a quote public option, where you would be replacing high paying patients with private insurance with lower paying patients on government insurance. So this is a precursor of things to come that you could see under a government run system.
Yeah, and that's the interesting part. You can actually see what's going to happen. We've spent $100 billion to prop up our hospital system due to all of this, and you talk about that too. I mean, you note that this might be an indication of the future, noting that our hospitals are underfunded because they're getting a different patient mix. And now they might have extra expenses like buying more PPE and all that. But the real cost is what you mentioned. It's the change in patient mix. And so, because you see these, we see these estimates on what a Medicare for all would look like. And I've had Charles Blahouse on the podcast a couple times talking about that. And, what he notes is that every time somebody references his work, and it's well referenced, it's the left and the right that reference his work, right. It seems like. But he's like, hey, guys, you're all referencing the lower end. All of you. Stop referencing the lower end of my estimate. It's actually, because it's $32 trillion is the lower end. And that's just the extra federal spending. That's not total spending. And he's like, guys, it's definitely closer to 40. It's just I think that's funny. Anyway, the point is that's still a conservative estimate.
Yes.
Just based on what the extra federal spending would be. It doesn't take into account things like we're doing right now, like injecting $100 billion, which is now going to look like $100 billion possibly every few weeks into the system. It's a lot of money.
Well, and Congress also, in addition to that $100 billion fund, Congress also increased Medicare payments for COVID patients by 20%. And that assumption is not built into any of those estimates of single payer.
Yeah, that's true.
Chuck Blahouse's estimate assumed that single payer would use Medicare rates across the board. If you end up using Medicare plus 20%, well, raise that $32 trillion by 20%.
Right, exactly.
If the Urban Institute estimated a 10 to 15% increase in Medicare payments, because hospitals currently lose money on every Medicare patient they treat. Their negative margin was about 8 to 9%. In other words, they lose 8 to 9 cents on the dollar for every Medicare patient they treat. the Urban Institute estimated a 10 to 15% increase in Medicare payment levels, not a 20% increase. So even their estimate was a lowball estimate if we have to increase payments by 20% across the board as we did for COVID.
Right. It's such important pieces of information for people to know. Okay, so I think we've beaten that dead horse. We know that we would be worse off with during COVID-19 if we had a single payer system. And again, people have to understand why that is. It's, first of all, everybody who needs care is getting it. So the more moralistic notion that the left comes up with that we don't want to leave people without care, which again, I don't really disagree with. That's a noble pursuit, and I don't want to say otherwise. But the reality is that right now, everybody who needs care gets it. The reality is that if you need emergency care in this country, you always get it. Doesn't mean our system is efficiently run, right? And that because that's their counter argument. Wouldn't it be more efficient just to have everybody have some kind of insurance? But there are consequences to that over-promising, and the consequences in a time like this crisis would be really, really bad. Again, New York City was at capacity, like really on the edge of being at capacity, but they've never really been broken. And that's kind of amazing that a city that large, that populated, that densely populated with such an outbreak of this virus, it is fundamentally true that it was strained but not broken the way other healthcare systems around the world were. Mostly European countries. I mean, and that's just worth noting. So, but doesn't change the fact that our healthcare system is not perfect and is too damn expensive. So now I don't think we'll ever get to the same kind of per capita healthcare costs that say Canada and UK have, just because again, they ration care to such an extent. They have so little innovation. They have so little capacity that's why it's lower. They're literally paying less for less. But that doesn't, I'm sure we've got to be able to make our system more efficient somehow. I mean, what are some of your favorite solutions that we could incrementally put in?
So I actually wrote a piece in the Federalist about this very recently. I agree with the critique from the left that we need to move away from employer-based health insurance over time. Folks on the left are using the shutdowns and the economic disruption from coronaviruses to say, this is why we shouldn't have employer-based health insurance. Because people, if they get laid off, they get furloughed. Certainly if we go into a steep recession, a lot of people will lose their health insurance, and that's a bad outcome.
Right.
So I agree with them on the problem. I disagree with them on the solution.
Yeah.
I think actually the Trump administration, and this has been rather unheralded, but I've tried to talk about it. I mentioned it in the last chapter of my book, and I've written about it extensively, actually created a new avenue to make health insurance more portable. And it's the health reimbursement arrangement. And how that works is you can buy health insurance, you as an individual, but your employer can provide a contribution on a tax-free basis to help you pay for your own health coverage. That way, when you lose your job, you don't lose your own health coverage. You can pick the coverage you want that fits your needs, that has the provider network that you care about, that your doctor, and you're the one that's in control. The additional competition can help bring down prices. And then it's portable, that you can take it from job to job and potentially even into retirement as you get older. That's the kind of system that we need to move towards, where individuals own their own health insurance rather than employers owning health insurance as currently happens, or the left solution to have the government run everything.
Yeah, I would fully agree with that. I don't think conservatives have ever fully defended the employer-based health insurance. I mean, what we note is that, it's people like it. But if we were to design that system, we never would design it that way. It got designed that way back in after World War II for and that was because of price. It was designed that way. If I'm make sure my memory serves me correct here, because we said that wages couldn't go above we put a wage control in, and so employers had to attract people to work for them by giving them extra benefits. Is that sort of how it happened?
I think that's exactly right. It happened during World War II. I've joked to my students that Hitler's the reason why we have the
blame everything on Hitler,
the crazy healthcare system we have. But there were wartime wage and price controls, and unions went and employers went to the federal government and said, could we exempt fringe benefits from taxation? And that is why benefits are provided. You don't pay income tax, you don't pay payroll tax on your health insurance benefits. And that really led to the employer-sponsored system that we have today.
Yeah, and it's got to be more portable and individualized. And so what can Congress do to aid in getting us towards that system?
I think the Trump administration did the best that they could in terms of allowing health reimbursement arrangements. Ideally, though, the better option is a health savings account model to allow health savings accounts to pay for health insurance, which they cannot under most circumstances right now. That would create a system that is more portable. Employers right now, under the Trump administration, the regulatory system, they can provide a contribution each month into a health reimbursement arrangement.
Yeah.
And employees can use that to pay for health insurance. Unfortunately, that money in the HRA belongs to the employer, not the employee.
Right.
If we had HSAs that could pay for health insurance premiums, then the employer could provide money in an HSA for an individual, and the individual would control that, such that if the individual gets laid off, they may say, well, I've saved up $5,000 in my HSA over the years. I can use that $5,000 to pay for health insurance on a tax-free basis so that I have 4 or 6 or 8 months of health insurance premiums already saved up, so you don't face the problem of having to shell out of your pocket for COBRA or your full without any savings when you leave a job if you get laid off, like we're seeing right now with recession.
It's actually, I want to use Republicans generally want to use HSAs as the vehicle for most of our healthcare ideas. One thing I like to talk about is direct primary care and how we could use HSAs to pay for direct primary care, take primary care out of the insurance problem solving question, and thereby getting more people access to primary care, which would be enormously beneficial, but also making the insurance problem easier to solve. I've actually not been able to figure out what the true why the left doesn't like the HSA route, and why they're always fighting us on that. That's honestly unclear to me.
In terms of the left's critique of HSAs, I think they primarily it's from a class warfare perspective, that they view it as a tax shelter for the rich. The data from America's health insurance plans and other entities suggests otherwise, that individuals of modest means are contributing to their HSAs, particularly if you have employers making contributions on behalf of workers to HSAs, which they can do.
It seems to me the obvious solution to that, we're already subsidizing people in these extremely complicated ways. You could just redirect those subsidies to lower income people's HSAs.
Correct. But that would allow individuals to control their own health coverage, whereas most folks on the left want the government to control it.
Yeah. I guess that's the problem. I guess that's the main main point of disagreement. Why aren't we good about messaging that better? I mean, it's because it's an honest critique of the right. Well, fine. What's your healthcare plan? Fine. What's your healthcare plan? Right. And we can't describe that in 5 seconds the way you can describe Medicare for all in 5 seconds.
Well, free stuff is, you can describe that very easily, as opposed to the argument against free stuff. I think, frankly, conservatives have shied away from the healthcare issue. And it's something, I appreciate you being willing to do these sorts of podcasts and get out there and talk about it, because you can't beat something with nothing. And I know this as having worked in health policy 10, 15 years. I've seen members of Congress, whom I'm not going to name, but smart, intelligent, good conservative members of Congress who really don't like talking about health insurance. Health care. They only talk about it when they're forced to talk about it. Don't understand the issue and don't really want to tackle it in depth. Whereas I think if you are interested in keeping taxes low, if you're interested in a strong national defense, you have to care passionately about health care as a conservative, because it's eating our country's budget alive.
Yeah, it certainly is. And on, you mentioned that Medicare is going insolvent by 2026, or at least a portion of it, right? Is that Medicare Part A?
That's the Part A. That's the Hospital Insurance Trust Fund. Yep.
Yeah. What how do you think we extend the lifespan of that? How do you think we extend that out? I mean, it's not looking good right now, considering the economic downturn we're in. I imagine that 2026 could actually be estimated to be even sooner now. Yep. But what should Congress be doing about that?
I think it's something, and frankly, Republicans and Democrats, a lot of them on both sides, have ignored this issue for too long. I think we need to start having a debate about reforms and entitlement reforms to the system. I think it's going to require making some tough choices potentially. I think definitely means testing is something we do now for Parts B and D of Medicare. Putting in more means testing. I think it's ridiculous that a Bill Gates or a Warren Buffett gets a subsidy from the government to pay for their health care.
100%. Yeah.
In retirement. There's been some means testing. There was actually some means testing included in Obamacare. It was one of the few portions of Obamacare that I thought was good policy. But I think we need to expand doing that and do more of that. I think we also need to go back and look at premium support. The Congressional Budget Office in 2017 outlined a premium support proposal that would save individuals, that would save the federal government money and save individuals money.
Like how is that not just the obvious answer that we can all just agree on? You know, it's mind blowing. And we'll explain premium support to people real quick.
So premium support is that Medicare Advantage plans, which are private health insurance plans, compete head-to-head against traditional Medicare to offer Medicare services. And you would get a defined subsidy from the federal government based on the bids of all those plans in a given area. And a senior could select the plan that's best for them. And it would work very similar to the way the Obamacare subsidies do. It's the ironic thing that the left decries premium support as vouchers and privatized health care, et cetera, when really it's using the exact same mechanism that the Obamacare exchanges have right now.
And it's essentially expanding on the idea of Medicare Advantage.
Correct. And it's allowing Medicare Advantage to compete head-to-head with traditional Medicare. Right now, as I point out in the book, and it shows the bias in favor of the government-run system. Right now, when you sign up for Medicare, you're not enrolled in the cheapest plan. You're not enrolled in the best plan. You're not enrolled in the plan that has your doctors. You are automatically enrolled in the government-run plan. And then a private health insurer has to do something to try to induce you to join their private system. Well, why are we automatically enrolling people in the government plan as opposed to the cheapest plan or the best plan for them?
Right. What about the argument that a lot of Democrats make that if we change the Medicare age to like 50, that's just a way to expand people who get the care, but they claim that would actually save money because you'd get access to care earlier and therefore not have as many health problems in older age. Is that a valid argument?
First of all, the under 65 population, the near retirees, have some of the highest rates of health insurance coverage nationwide.
Yeah. Well, they've had their whole lives to build up a career and have a job.
Correct.
And so, yeah.
And it's also, there was an op-ed in the Wall Street Journal recently saying that this also benefits the affluent. So you're benefiting affluent people who already have health insurance. They would get health insurance. It would just be the federal government subsidizing them to do something that they're already doing with their own money. That's not very efficient.
Right. But young people would be subsidizing people in their 50s.
Correct.
I mean, that's
correct.
This is what I remind everyone about the left's plan on Social Security, which is their plan is to increase benefits across the board for seniors and increase payroll taxes. And I'm like, you guys realize that's a direct transfer of wealth from millennials to your grandparents.
Correct. Correct.
And, if you think that's fair, then by all means, keep voting for that. But that doesn't seem efficient to me, especially when the number one indicator of wealth is age.
Yep.
And yeah, so like you said, it doesn't seem like the health outcomes would be any better because they're mostly already insured, highest rate of insurance, and also, yeah, it's a pretty unfair and inefficient transfer of wealth. I mean, what about the opposite direction? Should we be raising the Medicare age since we're all living longer, or is that more of an argument for Social Security? What do you think?
Well, I think that's one of the things we're going to have to look at, and I think, as I said, we've been avoiding this issue for far too long. Medicare is already functionally insolvent. Obamacare, in 2009, right before Obamacare passed, the projected insolvency date of the Medicare Trust Fund was 2017, i.e. 3 years ago. Obamacare reduced Medicare spending and raised Medicare taxes in a way that used the funds both to pay for Obamacare and to increase Medicare solvency. In other words, it increased Medicare solvency on paper. It didn't do anything. And that allowed President Obama for the rest of his term to avoid the issue. And certainly we've seen the past 12 years, we've seen no progress on the issue whatsoever.
As far as solvency.
As far as solvency, as far as any entitlements, that's Medicare, that's Social Security, anything. And I think we're going to have a difficult conversation about that. I think it's going to involve potentially raising the retirement age. It's going to involve means testing. Hopefully it will encompass some kind of premium support solution. But we're taking on more debt right now to pay for coronavirus treatment and the recession, which is understandable. We're in the middle of a crisis, but we don't have a heck of a lot of time to address this other issue of our unsustainable retirement entitlements as the baby boomers continue to retire. And that conversation is going to happen sooner rather than later.
Yeah, and a lot of that money under Obamacare, it was also a large transfer of money to Medicaid. A lot of people argue that if you were to describe Obamacare simply, it was basically transferring money from Peter to pay Paul and expanding Medicaid. Not so much expanding individual insurance. It's kind of a minor part of it all. It was mostly Medicaid expansion. Have you done a lot of work on Medicaid and the general debate? I get asked a lot in Texas on this question, like, why didn't Texas expand Medicaid? Aren't you guys just a bunch of evil Republicans for not doing that? I mean, there's obviously some logic behind that. Have you written about this?
I mean, I think the best argument against the Medicaid expansion is what it does to individuals with disabilities. That states get a 90% match to cover able-bodied adults, but they only get a 50 to 75% match to cover individuals with disabilities. There are about 700,000 individuals with disabilities on waiting lists for care nationwide. The idea that any state should be expanding their Medicaid programs to able-bodied adults, if they even have one individual with disability on a waiting list for care, strikes me as callous and immoral.
That's a pretty good argument. And as far as so there's that part. And what about fiscal sustainability of it? Because I think that's I would have to bring in some folks from the Texas government who were actually making those decisions to really get that answer. But there's a fiscal side to it also, and just the sustainability question.
Medicaid has roughly tripled as a percentage of state budgets in the past 3 decades. And so every dollar you spend on Medicaid is less money to spend on schools, less money to spend on transportation, less money to spend on corrections and other important state needs. And you've seen that consistently across the board, that other elements of state budgets are being squeezed as states spend more and more and more and more of their money on Medicaid.
Yeah, and then ask for more and more federal spending. There's a sort of weird notion in American life that if it comes from federal government, then it's free. But
yeah,
like we have got to come to terms with that false conception at some point. In Texas too, the way we have public hospitals that really care for the people with low income and care for the uninsured. So it's not as if these people don't get the care. It's just it's a different way of delivering that care. And you can argue about which is more efficient. It does seem to me that incentives are aligned in our current, at least in Harris Health system here, to get people healthy quickly and not coming back, which is a good thing. Now, I still think there needs to be more access to primary care. And I think we all agree on that. I like the direct primary care model myself. I'm currently looking at ways to get people access to primary care doctors via a direct primary care system, which is a simple and free market way to do it, which would again just very, very simply allowing people to pay for it with HSAs. And if you can't even afford that, because we're talking for direct primary care, we're talking on average $75 a month. It's a cell phone bill, and then that's full and total access to a primary care doctor. It's a great system. It exists in some parts of the country more than others, but I'd love to see that expanded and looking for ways to expand that. And for all our listeners, we're working on that. I don't want to get into too much detail, but that is the ultimate goal.
Yep.
Well, that was a good discussion, Chris. Anything else you want to add?
No, I think this does illustrate the point that the problems associated with single payer healthcare, and the point that conservatives need to come up with better solutions. And I'll certainly give a plug to my book. If people are on lockdown and they want to have an opportunity to read it, it's called The Case Against Single Payer. And just because Bernie Sanders dropped out of the presidential race doesn't mean this isn't a live issue, and will be an issue going forward. So folks can feel free to check out the book.
Yeah, it's a great read, very informative, and it's such a complex problem that is, and I think it's a disservice to the American people when we pretend that this complex problem can be solved with such a simple one-line solution, like, hey, just give everybody health insurance, Medicare for all. It's just not the case. We should have more honesty in our public conversations. So